I have been asked by Randy Waldman to go ahead and introduce this session. And first of all, we would like to thank Rytech for being a major sponsor of this event over not only this year, but consistently over the past few years, and really making this event possible for us. Okay, this is going to be a relatively short didactic, probably about 15 to 20 minutes over the essentials of portrait plasma resurfacing. Basically, plasma is a confusing term. It is really used to describe ionized gas. It's nitrogen gas that gets excited by ultra-high frequency energy, and that in a non-contact fashion is what is delivered to the skin in order to create the level of rejuvenation that we're desiring. So again, it's nitrogen gas that gets excited by ultra-high frequency energy. The key with this is that it's not really a laser, it's not really a light device, so it's a unique method of delivery of energy. It's non-chromophore dependent, and that's important, and it's also non-contact. The effect on the skin really is twofold. The first is the ablative portion, if you're going to use it at a high setting, called the zone of thermal damage. That's the level where the old epidermis sloughs away if you're using, again, at a high setting. You can turn it down. We'll talk about some of those. And also the zone of thermal modification, which I think is a unique attribute, where you're getting some of the changes around the area that you'll see histologically, and that's creating collagen rejuvenation over a period of about a year. The histology day zero, what you're seeing first of all is you're already getting some of the vacuolation. We're going to talk more specifically what vacuolation has in terms of clinical import in a moment, but that is essentially allowing you to double stack some of the passes, and it's also creating a barrier of safety during the regeneration. At the high setting, again, this is 3.5 joules at the high setting. What you're seeing here is the cleavage of the area where it was a zone of thermal damage, the area of intense damage, and the old epidermis being sloughed off. And you can see down on the bottom bracket the zone of thermal modification beginning to be apparent at this point, at day 4. But much more intensive at day 10. You can start seeing some of the fibroblast changes and activity down in the lower spectrum, and the old epidermis at this point has already sloughed off. So the healing phase is around a week, 7 to 10 days, depending on how high your settings are and how many passes you create. So essentially the way that I look at this in a summary fashion is that it's somewhere between trichloroacetic acid and carbon dioxide in terms of its efficacy, and the recovery is closer to TCA. Part of the reason why there is a better improvement, I think, than just traditional TCA is there's a wider zone of thermal modification. The zone of thermal damage is probably somewhat analogous, but there's also this deeper rejuvenation that continues to improve, and I can use it in thicker skin types that I can't do with TCA, but it's not quite a CO2 level. That being said, I think the other benefit, though, is the fact that even though it may not produce consistently CO2 results, you're also not getting the morbidity associated with CO2, which is prolonged recovery and hypopigmentation, as you guys well know. As I said earlier and alluded to, it's recovery very similar to a 35% TCA, and the skin remains intact like a TCA for a few days and serving as a biologic dressing. I think that helps expedite and help that recovery time to be shorter than a week. So the best way to think about the treatment protocols that are available, there is a new express version which is very, very low settings with almost no recovery time. I don't have experience with that, so I'm not going to really address that. But there's really two settings. The low setting at PSR1, that's just a name that the company came up with, and then the high setting at PSR2 and 3, which are the ablative modes. The PSR1 is a single pass. You're basically doing this over multiple treatments. It's an office-based procedure, very comfortable, and you don't get the ablative sloughing of the epidermis, but you do get some stripiness that lasts for about 3 to 5 days, depending on the amount of sun damage of the patient. The basic difference between a PSR2 and 3, terminology-wise, is whether you do a single pass across the face or you do a double pass. And a lot of times, for example, what I do is a hybrid, where I do a single pass over the face, and over the deeper wrinkles and deeper rhytids, I'll go back and pass it one more time. So it's almost sort of like a hybrid 2 and 3. Now, if you're wondering how come there's no jewels sitting between the two, why can't you just tune it between? They have found that if you're in the 2 to 3 joule range, you're getting the recovery of a 3 to 4 without the efficacy. So it's really, you have to look at sort of this divide of being a low or high setting. So this is a summary of what we just talked about before, that the lower settings, you're looking at the 1 joule per square centimeter setting. The high setting is something that, in my hands, I prefer to use sedation, although there's many techniques, especially if you talk to some of our dermatologic colleagues who are excellent in providing oral and maybe intramuscular sedation where you don't need intravenous sedation, or great extended blocks. In my hands, I find it much more comfortable to be in intravenous sedation mode. Again, really what you're looking at with the high setting, it's analogous to the other types of ablative modalities where you're getting about a one treatment deal. And it's safer really in the Fitzpatrick 1 through 3 range. The 4, I have not treated a 5, I've treated a few 4s, but basically my major spectrum is 1 through 3 using ablative settings. And I'll disclose that bias as I continue with this. By the way, I have not been paid by the company to give this talk this morning. The principle of evacuation, we hinted at this earlier histologically, and what you're seeing right here is the fact that what's going on in a Gaussian distribution is that you get the cells to evacuate, and that protects the cells as you're going over it one more time. If you look at the middle drawing, this is one pass where there's a Gaussian distribution of energy, but you can see there's a fall off of that energy. So between those energy spikes, you're getting maybe not as good as a result as you could. So in the deeper wrinkles, and some people like going back and doing a full PSR3 where they're hitting it twice, you can safely go back at a high setting and repass over that so that you get more of a deeper penetration in that area, because vacuolation is saving you. The one caveat is that there really isn't vacuolation at the low setting, so you really do not want to be double passing, triple passing on a 1 to 2 joule or 1 to 1.9 joule low setting. This is specifically referring to a high setting. The contraindications, clearly, I think you all know that Accutane would be one of them. Also, it's a pacemaker because it's an electrical device, and obviously a high Fitzpatrick's score. Into the 4s if you're doing the high settings, and 5, 6s if you're doing the low settings, would be a contraindication. So what are some of the things that you need to know before you treat the patient? Well, essentially, obviously, a lot of these things are sort of overlapping with traditional ablative treatments. 3 months prior, stop tanning. 1 month prior, any retinoids like Retin A. And 1 week prior, stopping all scrubs. I think that's something that's unique with this, and it's the outer stratum corneum serves as a protective feature for your skin as you're doing this. So especially the day of the procedure, and really no scrubbing in the stratum corneum, leaving that intact, and using no acetone or alcohol because this is flammable. So it's important that you don't clean it like you may do with the TCA peel, for example. So treatment principles, you hydrate the skin before. A great use is a topical anesthetic like benzocaine, lidocaine, tetracaine, because you're getting 2 effects with it, both the hydration as well as the anesthetic. I usually just hydrate for about half an hour, but I think it's somewhere between half an hour to an hour. The reason is that I do a lot of combinations with fat grafting. Most of my before and afters are with fat grafting. It's just a technique that I do. I have a press release coming out with these guys about how to use it with fat grafting. But again, you may be doing it differently than me, so I just disclose that bias that I have. It is flammable, so again, the acetone alcohol is an important thing to avoid, as well as turning off the oxygen. So if you got to remember to do that during the treatments. Protecting the eyelashes. I was going to go through a little video of how to do this, but with Dr. Garcia doing it, that's sort of redundant. But you want to protect the eyelashes. What I usually do is just use a moistened tongue blade, flip the lower lashes up as I treat across that. And then while I'm doing all the areas near the hairline, I use a folded, wet, moistened 4x4. And my assistant helps hold the inferior, I hold the superior, and I just basically trace up and down in a vertical fashion. But the key also is because the energy is actually beginning to it's a high depot of energy. You don't want to snake back and forth like you may do with a CO2. You want to go in a linear tracking fashion, so from, let's say, left to right, not left, right, left, right. Technique, basically, this is again a bit redundant, but some of the elements is after the BLT, sit there, you wipe it off. What I really have found a great thing is I like marking all the subunits out like I would do for a TCA peel. The great thing with marking the subunits is that since this is non-chromophore dependent, you can use a black pen. I use an eyebrow crayon because they can wipe off pretty easily, and I'll mark all the subunits out, and I'll actually further subdivide the cheek because the cheek is a massive area, and I just like dividing it either in quadrants or just one across that way. And that just helps me know where I was. Because the thing about this versus CO2 is that you really don't see exactly where you were unless you're dealing with significantly sun-damaged skin. Then you see more this glisten pattern where you were. So to keep me consistent, I mark all the subunits out with an eyebrow pencil. And I start with a low setting at 3 joules. I think it's a safe setting. You don't want to go too high around the eyes. So I do basically a single pass of 3 joules around the eyes. And then 3.5 joules, sometimes double passing, at a faster speed at 1.5 hertz. The hertz are just basically how fast you're going, and I found that around the eyes, just being a little bit more slow, a little bit slower at 1 hertz is good, and then going to 1.5 hertz for the rest of the face. In my hands, it's about right. 2 hertz is a little bit too fast for me to control a good outcome, but clearly in your hands it could be different. This is, again, a relatively early result, about 3 months out, again combined with fat grafting upper left. There's a better texture tone. I always tell my patients that this is not CO2. It's not going to eliminate all the deep rhytids, but it's going to get a nice improvement, texture tone specifically, especially, as well as finer wrinkles and some deeper wrinkles as well. And this is about 9 months out, fat grafting upper eyelids and rhytid. These are all high settings, by the way, at 3.5, with a few double passes. And this is a little Botox in the forehead too, but fat grafting and Rytec, and this is about 9 months out, 9 months out. And this is an interesting use of it. It's a lady that had a CO2 laser with a demarcation on the jawline. I went back and feathered it, and I think it's a little bit softer at 6 months along the jawline after treatment there. So in my practice, how do I use it? I use pixel therapies, fractionate therapies, instead of the PSR1. I'm almost basically always a hybrid PSR2-3 guy, and so I have a bias with that, and my bias is combining most of all my procedures with fat grafting. It's just, to me, it's a great way for me to achieve a better result for a patient, and combining rhytid treatment as well as with volume treatments. And I have combined it with facelifts. If it's more of a limited SMAS dissection, I do both in combination. And I'm pretty much a full face guy, although the nice thing what the company has mentioned, I don't have a lot of experience with it, is that regional treatments are relatively safe in terms of not creating demarcation zones that you may see with more aggressive ablative technology. My take-home points for you today, besides some of the pearls that I may have offered you, is the fact that I really see this as not being the perfect treatment modality for really, really deep rhytids, but in my opinion, given the efficacy and the safety, it's probably out there being much better in that I can treat almost all Fitzpatrick 1 through 3s, whereas with TCAs, I really had to hand select my patients for very thin skin to get a great result. If they're getting into the deeper, thicker skins, I just didn't see much change in their appearance, and I really don't have extensive experience with phenol. I think the nice thing about this is it's not cardiotoxic, but it's also the fact that it's very easy with good hands to deliver that. With phenol, is having a harder time just getting what I wanted to do in a safe fashion. So basically, the other nice thing about it, with the zonothermal modification, you do get ongoing improvement over a period of a year.